let's pivot now to talk about another piece of anatomy down the arm, which is the elbow. So let's take a moment and just go back to the anatomy. Do you want to draw a little sketch of how the humerus lines up with the ulnar and the radius?
Very much so.
All right. So the big diagram is looking straight at the antecubital fossa. And then obviously the side diagram is showing the arm flexed. So walk people through what these three bones are, and then the sort of overlaying muscles.
So this is, as you said, the front of the elbow is here. The humerus bone, which is the arm bone, is coming down. You can see it's a super weird undulating structure there, which makes it intrinsically quite stable. So much different
because there's more to dig into.
Exactly. Yeah. There's all these fun little, almost jigsaw puzzle pieces that stick together. We have the radial head, which is the rotating bone of the forearm. And then we have the ulna, which is the fixed straight bone of the forearm. And then we have what's cool about the elbow is the tendons that go down to the forearm and to the hand originate above the joint, more or less, right? Close juxtaarticular, close to the joint, but above it. And then the ones that go from the shoulder and arm down attach below the joint. And this is the biceps tendon here, the big biceps muscle here, the biceps tendon attaching to the radius. And we'll talk about that. This is the lateral side, the outside of your elbow. And the blue is the muscle tendon units that are attached there, anchored to this little circle or oval. And then the red part is where tearing typically occurs in tennis elbow. On the inside of the elbow, where our funny bone nerve is, the funny bone nerve is the ulnar nerve, and that's the green structure in cross section. And then overlying that is the muscles, the flexor pronator muscles that help bend the elbow and pronate the forearm. And those can tear right in this region, and that's actually where we get golfer's elbow, and what it's known as golfer's elbow, which is medial epicondylitis, medial. And then the lateral side, which is the tennis elbow, is lateral epicondylitis. And those are these three, the biceps tendon and these two, are the most common tendon injuries by far. The fourth, which is less common, is shown in the lateral, which is the triceps coming down and attaching to the tip of our elbow. We talked about the bursa before, and there is a bursa right here that lives over the tip of our elbow, and we can get the big golf ball size filling of fluid, and that's the olecranon bursa. And so I think it's beyond what we're talking about today to go into the fractures, but any parts of these can be broken. And the elbow is a very finicky joint. You can see it's stable because of those undulating surfaces, but because they're undulating,
there's less wiggle room.
There's less wiggle room, and if you don't get those things perfect when you fix them, they can quickly lead to arthritis. And some of even the subtle fracture patterns that happen and aren't seen or appreciated can lead to rapid destruction of the joint. So it's a finicky joint.
Wow.
It is also, I've drawn this blue structure here, which is a very thick ligament on the inside of the elbow. That is the Tommy John ligament. It's not really Tommy John. And even, I'll clarify that in a minute, but that's the medial collateral ligament or the ulnar collateral ligament. And that's the one that's torn in throwing athletes. And that's can be career ending, except now because of the reconstructive surgery, it's generally not.
So let's talk just briefly about why the lateral epicondyle, if there's inflammation in that tendon, we sort of think of that as the injury a tennis player gets, whereas inflammation in the medial tendon is more attributed to what a golfer gets. Of course, people who have never played tennis or golf often get these things, but it could be illustrative just to explain the movement pattern.
It's great. So those are not dissimilar from the supraspinatus tendon, where they have a little ringing out and they kind of can become degenerative and partially tear. Just like we talked about rotator cuffs, there are tons of people walking down the streets with partial tears in those tendons, and they're asymptomatic. Use patterns are significant for that. The reason the lateral was historically associated and called tennis elbow is because of one-handed backhands. It's a much less mechanically sound, and we have less strength with our external rotators than we have with our pectoralis and our subscapularis for forehand shots, so it's under more stress. And you can get them at any age, but the sweet spot of treating this is 40 to 60. 40 to 60 now, that is creeping up to the 70s and so forth, because again, people are so active. So that's why it's been associated with tennis elbow. Ironically, now I'm seeing just as much in tennis players and competitive tennis players, I'm seeing just as much medial epicondylitis, which is traditionally golfer's elbow. And the reason is because everybody is trying to hit massive topspin. And they are using their pronator so much more than they used to when I was a kid and playing. I try to hit topspin now. And so that's a reason why it's stimulated more.
Why does the golfer get it? I don't play golf, so I don't appreciate it.
So historically, even though golfers were getting it, I don't know why, because you're not supposed to be, it's overhitting with your trailing arm. Most people play right-handed, and they were getting it on their right medial epicondylitis because they were overhitting, hitting stumps, hitting rocks, duffing. And it was that jolt, again, the eccentric load on these tendons, which our tendons don't like. But I'm seeing now, because people are hitting so much harder, they're hitting bigger clubs, especially drivers and such, they're getting more left leading arm lateral epicondylitis in golfers.
On the leading arm.
On the leading arm.
Makes sense.
Because that's more logical, actually.
Yeah.
But they're just trying to hit harder and farther. And, once these big hitters are on there, they're trying to mimic them and so forth. So,
is the first line treatment for that rest,
yes,
followed by, rest and NSAIDs, presumably followed by cortisone and things of that nature?
Right. So the first line of treatment is rest, good stretching, just like you stretch your hamstrings to keep from tearing them as frequently or injuring them as frequently, and usually just NSAIDs by mouth. If they're on, rarely do I use physical therapy for these formally, because it's just not much to do. But if they're just too painful to even, some people wake up in the morning, they can't even straighten their elbow out. They're so painful. They're so spongy and really inflamed. So those, I still don't splint them, but I have them stretch. But more often, because they can't use their arm, I will go ahead and give them kind of a half dose of cortisone just to cool everything down. And
you injected me probably 4 or 5 years ago when I was sort of in the transition of really learning how to control my scapula, and had sort of overcooked too many pull-ups. And all this pull-up pain was translating into tennis elbow. I was surprised at, and it was stubborn. I mean, I came to you after 6 months of pain, but that one injection cooled it off. And it never hurt again. Because basically I had already fixed the underlying movement pattern. I just needed to cool the fire off. Is that a common scenario?
It really is. It really is. And again, I don't operate on, because it's so common, I end up doing a lot of these procedures, but I don't operate on, I'd say 1 out of 5 at the most, 20% at the most. Most people get better.
And so operating on the lateral versus the medial side, what are the indications?
The indications are the same: failing conservative treatment, a lot of stretching, a lot of strengthening. A lot of people get these. In your case, it was mechanics overdoing, but a lot of people get these because they're getting back into something that they haven't been doing in a long time, and they overdo it. And it can be just weights and weightlifting, but honestly, it's something as mundane. I'll see these after people have gone traveling for 2 weeks, just lifting their luggage, dragging their luggage around. So it's all comers, but the theme is that conditioning, if they've had it chronically, not in your case, of course, but a lot of people come in and they're already kind of weak. They don't have strong grip strength. They don't have good tone. And so strengthening is a critical component. If they can squeeze I have one of my devices, if they can squeeze that without just a little pain, then I just have them do that first, stretching and strengthening.
Okay.
And sometimes that'll cure it, and often it'll cure it. But if they can't squeeze it without undue pain, I give them a little dose of cortisone. If it's chronic like yours was, then there's not that much to do. You're fit, you're got great tone and you've got full motion. So it's only, give it a little booster dose just to knock it out. We think sometimes, we haven't ever done the study to prove it, but we think sometimes just sticking the needle in a few times kind of stimulates a healing response.
Yeah, I've certainly seen a lot of anecdotal stuff around dry needling, just getting the dry needle in there.
Yeah, I believe in that.
Yeah, and just increasing the influx of inflammatory cells and cleaning up, getting macrophages to come and clean it up.
Yeah.
So outside of fractures, how often are you seeing acute injuries to the elbow that ultimately are surgical cases?
Yep. So one of the common ones is the middle-aged but very active, fit person who maybe had a little antecedent elbow pain or forearm pain. They didn't quite know what it was, but they did workarounds, and then they ruptured their distal biceps. And so they get a Popeye muscle. It's all weird and even quivering. And they come in, they go, oh my God, you've got to do something. And the cool thing about the bicep, we think of the biceps as being, we do biceps curls.
Right, it's an elbow flexor.
But it is a secondary elbow flexor, but it's the primary supinator of the forearm. So people come in and they lose, when they tear their biceps, they don't lose that much flexion strength, but they lose most of their supination strength. So if they are used to turning screwdrivers, wrenches, even surgical instruments, maybe depending on what they do, then it can be really disabling. So
that factors into the physical exam, then, doesn't it?
Oh yeah. And it's funny. They'll come in, they won't be painful. They'll say, "I think it's better, and I've got this, but I can live with the deformity," which I don't care about the deformity either. And then I will pronate them to wrap that tendon kind of around the radius, and then I have them pull up like they're doing a pronated curl, and they scream. And it's just, you get it just isolated, and that's a very good point about that. And then you test their supination. They didn't know that they didn't have any supination strength. Then you test their other side, and they can lift you off the table, and then this side they can't even do it. So
when you surgically repair that, are you reattaching the tendon? At same place. So it's like a tendonesis.
Yeah, it's great. It's a great operation.
So that's a good outcome operation.
Oh yeah. I had a guy in the other day, just looks just like you, good strong arms and everything, and he's doing this all the time, and he ruptured his, and he came back in for actually with his son, and he said, "Man, if you need anybody to," he said, "my arm is stronger than it's been in a long time," and that's I'll speak to that, but he said, if you need somebody to call anybody to talk to him about how great this operation is, just let me know. But he said a lot of them say, I feel almost like I'm stronger than I was before. Well, you're only putting it back where it came from, but they probably had a partial tear for a long time. They were working around. They were a little deconditioned in their biceps. They were compensating with their brachialis, the big muscle underneath that. And and then they get even stronger because they have a good tendon again.